Hello everyone, welcome to the second panel session from Promise to Practice. And as we did with the first, we want to start by just getting everyone on Slido to check that you're on and ready to submit some questions. So again, we're going to ask you another poll question, just a bit of fun. We're going to ask you, how ready do you think is the NHS to realise the potential of AI? So just have a quick vote and let's see what you're saying. We've got ready now, nearly ready, still some way to go, and still a long way to go. So it looks like still some way to go. So kind of 2 cheers for where we are at the moment. This is part of what we want to discuss in this panel session now. We started today at the very high level with the Minister thinking about strategy and then talking to senior government officials. And then we've just heard in detail from the leader of a major healthcare organisation in the US overseeing this agenda. We now want to keep this movement down right to the coalface on the ground to think about and talk with guests about how AI is being implemented, embedded and deployed in practice. To do that, I'm delighted to be joined, first of all, by 3 Health Foundation award holders and partners. Adnan Tufail, a consultant ophthalmologist at Moorfields Eye Hospital, Mary Dixon-Woods, Director of the Healthcare Improvement Studies Institute, and Erik Mayer, Clinical Associate Professor at Imperial College Healthcare. And I'm also thrilled that we're joined by Dr. Aysha Lewis, Principal AI Scientist at Newton's Tree, who are a company that supports healthcare providers to deploy and monitor AI tools. So what I've asked each panellist, the first 3 panellists to do, is to reflect a bit on the work that they've done as part of their award with the Health Foundation. Then we're going to step back and be reflecting on whether we can crack the question in this session title, how do we know if AI is safe and effective and how can it be scaled? So without further ado, Adnan, could I hand over to you to hear about your work?
Great, thank you. I've just got one slide, which is a visual. As an eye doctor, we're very visual. I have a visual representation of the back of the eye. So this is my one slide. So we heard before the break, both by my colleagues in Norway and Catalonia, that they prioritized diabetic retinopathy as a key area of deployment for AI. And as an eye doctor, diabetic retinopathy is really important. It's the commonest cause of visual loss in the working age population in most Western countries. And we have over 4 million diabetics in the UK. And we need to identify these subtle changes at the back of the eye. So diabetes damages the little blood vessels at the back of the eye. And we can see those changes before it drops vision. And eventually the back of the eye is starved of blood and it grows blood vessels that you can see on the bottom picture. And once you get those blood vessels, they can bleed and hemorrhage into the eye and cause severe visual loss. There's a large asymptomatic time where we can see these changes before they get the bleeds. And we have extremely good treatments that are highly effective at stopping visual loss. So really, this meets all the WHO criteria for screening. And we're very fortunate in the UK, for the last 20-odd years, we've had very effective screening. And what screening involves is patients, once a year, get photographs of the eyes, at least 2 pictures per eye, and they're looked at by 3 levels of trained technician graders. And that means we have 4 million diabetics, which generates almost 20 million images a year, that have to be looked at. We have a shortfall of graders every year. We talked about workforce shortages, and we have an increasing burden of diabetes. So we are struggling to be able to manage this really good screening program. And I've got interested in AI a long time ago because my original research was viral infections of the retina. And even over 20 years ago, we were working on computer vision modules to detect those things. And when I came back after trying to work on this, we realized even 20 years ago that there were already CE-marked algorithms to try and look at diabetic retinopathy. But what we didn't have is good independent ways of testing this. So together with a team from George's, Moorfields, UCL, the Homerton and London School of Economics, we've been working for over a decade at how we independently validate these algorithms. And the reason we need to independently validate them, most of these, as we've heard repeatedly during the day, have been tested on data sets that were not the patients we are intending to deploy these algorithms on. And our original study, we did a test on 20,000 patients with diabetes. And we did that because my colleague at St. George's did a power calculation that we really didn't want to miss this proliferative blood vessel disease. And that only occurs in 1% of patients a year. The FDA, in their regulatory study, only looked at 800 patients. That means you're looking at the safety of these algorithms on 8 events, which, even if it didn't miss anything, wouldn't give you a lot of confidence. So you need far more events. Even 80 or 800 would give you more confidence it didn't miss those. So hence the power calculation of 20,000 that far, far exceeds what the regulators suggest you should use. So we did our original study, but we were almost ahead of the curve, and the algorithms evolved and got better, and now there are 15-odd CE-marked algorithms. We're very fortunate that a few years ago, the Health Foundation kindly funded a study to look at all available algorithms and look beyond what we previously did on equity of performance. Because we know with the original deep learning algorithms, and we've heard before, there can be biases, they can be tested, as we heard on facial recognition algorithms. Originally, many of them were tested on white male faces, but as soon as you try and deploy them on other genders or races, their performance is less good. So we were funded to look at a study on equity of performance and also on patients' perception of AI and users of AI on how it may affect them. And so the study, which has been accepted in Lancet Digital Health and methodologies published in New England Journal of Medicine of AI, was looking at 200,000 patients. So it was properly powered for all the subgroups of the population. And it showed that these algorithms, and the 8 that we tested independently, we ran everything ourselves, were extremely good at detecting the most severe levels of retinopathy. And were all good no matter what subgroup of the population you had. Hugely reassuring for national deployment on 4 million. But where we saw a much greater variance was in the lower levels of retinopathy and the patients with no disease at all and how much they filtered out. And that would drive the value and the cost effectiveness. And there's a current health economics analysis going on with our colleagues at City University to do that. So we really, I think, got all the information now to provide to the Commissioners of Healthcare for the potential first mass deployment of AI in the UK. And we're also working on how to future-proof this now.
Yeah, and just say something on that. How do you future-proof it?
So there are a number of areas. We heard earlier about how rapidly new algorithms are being developed, and these vendors are already developing new algorithms. So we've designed a notion of iterative testing, where we can test these at regular intervals. Part of the benefit of the NHS, so we have huge data sets, so we can test the new algorithm rapidly, and we can run them at redundant systems. And what we also want is a competitive environment. So part of the reasoning of looking at multiple vendors is if they're as good or better than humans for not missing severe disease, then you have a competitive environment on pricing. And we want to have a system where we can retest them at X number of years, so you don't have a dominant player and don't encourage innovation going forward. So all of that is baked into the way we're doing this. We're also looking at monitoring systems post-deployment, and we're going to hear from our colleagues later in this session about potential ways of monitoring beyond what we're doing.
Thanks, Adnan. It's really interesting then. So how we go beyond self-reported results to do head-to-head comparisons when there are different tools available. Mary, I suppose Adnan's work's based on one particular challenge where you've got an algorithm trained on a subgroup and you want to know whether it's generalizable to others. I'm guessing there's lots of other challenges of evaluating AI as well. So over to you to talk about those.
There are indeed. And I think what we can learn a lot actually from the history of innovation and improvement in the NHS and more broadly. What we have is a pattern of lots of small-scale innovation happening locally, lots of small-scale improvement activities, which can do some good, but we have failed to get enough benefit from that because we don't evaluate thoroughly and we don't accumulate learning and we don't share it. What we also have is a lot of large-scale programs over the years, and one of the challenges there is that they often go to scale, are very expensive, but often lack the design and implementation to make them really work, and they also suffer from problems of evaluation. One simple example is that we looked at maternity care, where there were over 50 large-scale programs over a 13-year period, and only 15 of them had been evaluated, and most of them demonstrated defects. On the other hand, we do have an awful lot of learning about how to do large-scale programs, and I see AI as having many of the characteristics of a large-scale program. We have some of that learning from actually large-scale government programs, where over the years they have looked at all kinds of ways of delivering programs to the extent that we now have an authority that curates major projects on the major projects portfolio. The National Audit Office regularly reviews those and produces incredibly interesting and insightful reports about them. We have a huge academic literature on what are called mega projects, and we have a lot of learning, some of it done by people in this room, on large-scale programs in the NHS. So we actually know a lot about how to do this, and we also know that programs involving technology are characteristically complex interventions, where Andy said it a minute ago, tech is the easiest part in some ways, and we need to think about how tech is operating as a change program. Now, the challenges of these kinds of programs are multiple and very characteristic, so that they demonstrate repeating patterns. One of them is optimism bias. So they set out with a very ambitious vision for what's going to be achieved, and they think they're going to achieve it. Linked to that, we get problems of strategic misrepresentation, where the advocates for the program, not necessarily deliberately, but they do misrepresent the costs, the risks, and the benefits in order to get it funded. We have a major problem of uniqueness bias, which is that everybody thinks their solution is going to save the world, and that very rarely happens, but there's a sense in which people don't learn from previous programs. There's a major problem of not necessarily understanding the problem to be solved, and again, Andy said it, going straight to the solution without understanding what you're trying to achieve. Commonly, there is overcommitment to a particular solution too early on, so you get lock-in or capture, and then you get escalating commitment, where you continue to invest resources in a solution that may be suboptimal. We get lots of issues with large-scale programs in terms of suboptimal implementation. Again, many of them have been mentioned already today. Mundane things like procurement, budgeting, scheduling, all this stuff really matters. But we also have the stuff that sounds fluffy, but really is very tough, to do with engagement, to do with the work system design you need to deliver things, the governance structures, the institutional infrastructure necessary to success. So these are multi-actor processes. They require large-scale infrastructures and institutional architectures to deliver them. They tend to be pervaded by interests that need to be controlled, and you get principal-agent problems that emerge very quickly in relation to these technologies. They have a black box character, and multiple suppliers enter the field, and it's very difficult to understand what they are. Andy also said it, but we have pilotitis as a disease that the NHS suffers from repeatedly. We get things going to scale on the basis of small local evaluations that have been done in conditions that can never be reproduced. So we're now in a situation where we have a huge amount of learning about how we do this stuff, and I fear we're about to forget those very painfully won lessons. NP-FIT is a textbook classic in business schools for a reason.
This was the former national programme on IT.
This is, indeed,
yeah.
Yes, wasted billions. So we now have dilemmas. We have grand claims being made on the basis of fragile evidence that would not be considered acceptable for drugs. The imperative to save the NHS is invoked regularly to defend the need to be quicker and dirtier, but it's not really clear what's good enough. Effectiveness, safety, and large sums of public money are at stake. So we have to do better at this. But it is also true that traditional methods derived from biological science, while they have much learning, are not necessarily fitted for the world in which we now find ourselves. So what needs to happen? First, recognize that anything based on AI is a highly complex intervention. Second, recognize that proper evaluation and engagement at scale are likely to be features of getting the benefits that we would hope for. We have to find better ways of engaging at scale. We have to understand more about the problem to be solved, the solution design and implementation, and as we've heard repeatedly, post-deployment surveillance. We have to find better, faster ways of studying an intervention that may be mutating in real time and that has this profoundly socio-technical character. So I think we have to set minimum standards, not necessarily gold-plated ones for evaluations, and think about the institutional design we need for this new era. We need to identify what is valuable about the biomedical paradigm, including its emphasis on rigor and control of interests, but we also have to recognize it's not fully suited. We've got a demonstrator project that we're conducting in collaboration with the Health Foundation, where we're trying to provide some of the infrastructure for bringing people together, to share learning, to shape technologies as they emerge, but also very importantly to shape how they're implemented. And this is an online platform we are calling Avid, and it is currently being tested and about to go live, but this is going to combine some of the features of social media, the kind of things that people engage with now, but also, so a lot of user-generated content where people can ask questions, exchange information, but also stimulus provided by this institute in collaboration with NHS England. So we're beginning to get people engaged in how they will solve problems. That's currently in testing, but if you would be interested to sign up, we will admit you in about 2 weeks' time when it's ready to go live at scale. Thanks very much.
Thank you, Mary. Really exciting to hear about that work on ambient voice technology, but also just a hugely authoritative trawl through so many of the potential challenges and pitfalls with evaluating AI. We'll definitely be coming back to some of those, but Erik, let me pass on to you. What's the work you've been doing?
Right, Tim, thank you very much. So in some ways, it all kicked off actually when my partnership with the Health Foundation started through an Innovation for Improvement Award back in 2017, 2018, and thereafter through a scale spread and embed further funding after that. And it was a passion to really address what was an ethical dilemma that we had not only at Imperial, College Healthcare Trust, but also across the NHS around the programme of the Friends and Family Test. And we were, and would still today, obviously solicit feedback from our patients and carers around the care they have received. But often the mandated reported sort of requirement was, how many feedbacks have you collected? And so we had all this free text data there that we were not analysing. So at Imperial, typically getting about 20,000 comments a month. The patient experience teams in each of the NHS trusts or hospital typically average between about 1 and 3, if you're lucky. And you cannot get through that volume of free text data. So that's where our journey around utilising routinely collected data through our NHS system started, and how we then applied natural language processing to theme those comments and semantically assign them positive, negative, or neutral to then present back to the quality improvement teams the various areas that they then might want to focus on for what they do best around quality improvement initiatives. One of the most rememberable piece of that work was being able to go back to our staff and actually showing them all the evidence of actually the overwhelming positive feedback they were getting, not the assumption that it's always negative. And so for an organisational culture, that was huge, and particularly so this was as we walked into COVID, so that was an important thing for us. Thereafter, through the further funding, we then looked at how, I wouldn't say replicate that, but how we could scale it across other NHS organisations, recognising there's variation in patient experience team resource, quality improvement team resources, and a digital maturity of NHS organisations as well. So that was how that further work was then spread across 10 other NHS organisations. And it's a programme that's still live today. The code is freely available to other NHS entities and providers to carry on that work and embed it as they want to. But for me, that was really the beginning of our vision for how we wanted to set up an environment which is now recognised as a secure data environment. That's the iCare secure data environment, where we could, in near real time, ingest all the routinely collected healthcare data from Imperial College Healthcare Trust. So that's our main electronic patient records, which is Cerner, and the other linked downstream systems like pathology, ITU, radiology, all those systems. So we went live in 2014. We now have over 2 billion rows of structured data, but most importantly, we capture all the free text data. So that's 400 million records, all linked at the patient level. Ward round notes, dare I say it, blank notes, operation notes, outpatient letters, microbiology reports, all these sort of unstructured data. So what's that then allowed us to do is take forward a translational data analytics program of work in which we have an AI testbed in our secure data environment to really start to challenge some of our perceptions of risk assessment, for instance. Are we correctly identifying the patients who are at most risk of falls and therefore triggering the risk assessment? And actually, potentially, we're not. We're targeting the wrong patients. The value is in bringing together that unstructured data, so that free text data, like nursing entries and things like that, with the structured data. Because, of course, structured data is only as good as the input, which is fine. If you've got real-time blood pressure monitoring, pulse monitoring, temperature is fine. But when you're relying on people to code in the system, that's where the challenge becomes. So with our AI testbed, we have locked in, not public-facing open AI services, which has really then allowed us to latch on to the generative AI towards summation of information held in the electronic patient record. So we are doing work on discharge summaries. That's been mentioned a number of times already today. And it's fascinating going on that journey because, of course, the assumption is you just expose it to all the data in the EPR, and, of course, it then gets really confused. And it hallucinates massively. So we've gone through a piece of work with our resident doctors, identifying actually in real time, following them around with appropriate governance, which aspects of the documentation they go to first, second, third, fourth, fifth, to put together what they would do as a human as a clinical summary. And actually then if you present that information to the OpenAI services, large language models, it then starts to behave in the same way and you increase and improve the accuracy of the output. But some of the challenges around this is that although we are bringing researchers into secure data environments, they're not sharing data, it's all accessed within the secure data environment, we still obviously have to comply with robust governance in terms of de-identification of data. But that created some real challenges for us. So if you truly de-identify data or truly pseudonymize it, actually you take away the date and timestamp of the document. So then the AI doesn't know which order the documents were inputted into the system, so it gets things in totally the wrong order. So with our data protection office, we've now gone through a process where actually we can minimize that de-identification process to, again, allow the OpenAI services to perform and generate accurate clinical summaries. Now, for us, that isn't the end goal, just producing it in one form. It allows us to then produce it in multiple forms for different stakeholders, different languages. If the patient's being discharged to a care home via the care of the elderly services, actually you want to focus more around mobility factors and things like that. Is it for a GP? Is it for an inter-hospital transfer? Is it for safeguarding around paediatric discharges and things like that? So you can start to bespoke these models to make them very relevant and impactful. One big focus we have is very much on that pushing things back into the front-end systems. So it's not just research in isolation. It's the safe return piece. And there's the access to the data is relatively easy. The technology, strategy, and implementation to allow us to push things in the front-end systems is in some ways the harder challenge. But to what Mary's were talking about, actually, how do we then truly, through a data-driven form, evaluate that the performance of the things we're putting back in, the AI tools, the devices, the algorithms, behave in the way that we intended? And if it's a simple rule-based logic, it's going to behave in the same way, A plus B equals C, it's hard to break unless the data suddenly becomes missing. But if it's a true AI that's learning as it goes, my CEO says to me, if you implement this tomorrow, how's it going to behave in 24 hours, in 1 week, in 1 month? So how does that look like, not only from a quality safety perspective, but also from a regulatory perspective? And I think that's a space that this session today is really identifying.
It's really interesting. So you're painting this picture of these AI-enabled data analytics to understand the effectiveness of interventions in healthcare. I'm reflecting on some of the challenges we've already heard, the need to monitor things, the need to understand them in real time, and so on and so forth. Might it be then that AI is part of the answer to this question of how we evaluate AI?
I think it is. I'm going to choose my words carefully. So a degree of automation here, I think, is right. AI is a very ubiquitous term, but it's going to have to be, that degree of automation for evaluation is going to have to be part of it. Otherwise, it's not sustainable. In the same way, we've been on the same journey of how do you clean, curate, transform the data to make it research ready. You can't have an army of 400 data engineers in every NHS trust to do it. You have to automate it in a way. So we're going to have the same problems in the organisations, NHS hospitals, GP providers, community, mental health, where you're not going to be running 5 algorithms. You'll be running thousands of algorithms in an organisation, and you can't have a human resource that then does the evaluation piece. We're going to have to automate it very carefully.
Really interesting to hear. Aysha, what's your perspective on this? You're involved at Newton's Tree in pre-deployment testing all the way to post-deployment monitoring. Great to hear your thoughts.
Thanks, Tim, and thanks for the invitation. So I thought I'd begin by just giving an overview about what Newton's Tree is. So Newton's Tree is an enterprise deployment and monitoring platform, and we help hospitals select, test, deploy, and monitor AI. What that looks like in practice, I'll just walk you through an example scenario. So say you're a radiologist that has a chest X-ray backlog and you want to use AI to solve it. The first challenge that you have is choosing a vendor from all of the vendors that are out there in the marketplace. So we can help you do that. We can help you shortlist vendors that match your clinical needs. The next question that you might have is, how do you know if that algorithm or that product will work with your local population? And so we can help you test several tools head-to-head on your local data, so you can identify the best performing product on your local population. Often, healthcare organisations then fail at the next step, or struggle at the next step, which is integration and deployment, because we know our IT systems, our IT teams, are under-resourced, and it can take several months to deploy and integrate a solution. At Newton's Tree, we can integrate into PAC systems in one day. And then finally, once the solution is being used in the live environment, how do you know it's still working as intended? So for that, we provide a continuous automated monitoring solution that provides the assurance that the tool is supporting clinical decisions safely. I'd just like to take a moment here to just highlight the difference between evaluation and monitoring, because I found in my practice that people often use those words interchangeably. So I'm going to use a car analogy, so hopefully this will resonate with a lot of people out here. So when you think about evaluation, you're testing the product before it goes into live deployment. So think about that as your showroom visit. So that's when when you go to the showroom, you're asking, how does the car handle? What's the safety features? You might take it for a test drive. Monitoring is when the car is on the road. So that's when you're monitoring the dashboard, checking for warning lights. And when something goes wrong, that's when you don't ignore it. You have to fix it. Otherwise, it can be dangerous and harm people. And that's exactly the same as AI in healthcare. You can't test it once and assume that it'll always work perfectly. You need to keep an eye on it in the real world, because in the real world, we know that things change, data shifts. Pandemics happen, we've seen that happen. Hospitals install new scanners, vendors update their products. So in that situation, sorry, I've lost my train of thought.
I really like this distinction between evaluation and monitoring.
Yes.
Just let's make it real for a minute. Mary was talking about some of the work she's doing on ambient voice technology. What would kind of post-deployment monitoring of a technology like that look like?
Okay, so at Newton's Tree, I'll just finish off what I was about to say. So we take a clinical safety approach to monitoring. So we don't monitor just the AI's tool in isolation. We monitor the systems, monitor the environment around the AI. So we look at 3 critical factors. We look at the data going into the AI itself, and the end user. And we take this end-to-end view because then we can detect issues early, alert the teams, and then they can proactively do something about it before it causes harm. So with AVTs, we're taking that same principle because our approach is a general approach, and we've validated it in imaging, but it's not imaging specific. So the same underlying principle applies. we're providing a continuous real-time automated monitoring system that can monitor the data going into the AVT. So in this scenario, it would be the audio. We'd monitor the AVT itself, and then finally we monitor the end user kind of interaction. And we found that most of the risks kind of map to those like 3 domains.
Makes sense. On the end user interaction, I mean, Mary, AVT seems very much to be the flavour of the month. We saw that in the 10-year plan. It's been talked about a lot today. I know you're involved in looking at that as part of this. That end user bit and the whole socio-technical human system around it and the use of it, what are you looking out for there?
We're running 2 projects at the moment. One is looking at what happens to time use by GPs when you introduce ambient voice technology. So we've got time and motion methods that allow us to identify at a granular detail what GPs are spending their time doing, and we're going to look at whether that shifts using a controlled before and after study. In local trust in Cambridge, we're going to be looking at deployment, and that's a much broader ranging evaluation, which we're hoping is going to be scalable. So we've got a set of data items that we're going to be extracting from the electronic health record. We're going to be doing time and motion study using volunteer observers, and we're going to be using the ambient voice technology platform I've just showed you to get continuous feedback from staff alongside the Teams-based engagement that the Trust is going to be doing. Because I think that this is not going to work unless we solve all of these socio problems as well as the technical ones, and they're intimately interlinked.
It's fascinating. I want to open up some questions, but just before I do, Aysha, so just from your perspective in industry, I mean, I know you work in the NHS as well, but presumably it's an important question how different partners can collaborate on this. What kinds of collaboration make sense here? What are you seeing? What are you involved in?
So first of all, I think we need to be clear about respective responsibilities. So everybody has a role to play, and each of the role is essential. So in this kind of playing field, the regulators define the standards, industry kind of builds the tools to kind of meet that standards. Clinicians are responsible for making sure that the tools that they use are safe and effective. And then finally, everything is grounded in what the patients require of us, which is to deliver outcomes and to build value, to demonstrate value. We also have to recognise that this is a team sport, and that everyone is focused on has the same ultimate goal, which is to deliver a safe and effective healthcare system, which translates to better patient outcomes. At Newton's Tree, we've kind of fostered this collaboration through our shared monitoring framework. So we provide insights, so data-driven insights into the data itself, so the 3 kind of domains that we monitor, and we share that with NHS sites. We share that with regulators and vendors so that they can compare performance insights across different hospital organisations. And we think this collaboration is key because then it allows the vendors to respond faster, the regulators to act more proactively, and hospitals to feel supported, because right now all of that data sits in silos. So the vendor sees one thing, the hospital sees another, and then the regulators may not even see that until the future.
Yeah. Really interesting to hear. We've got questions coming in thick and fast. A couple of them are about skills. Are healthcare scientists involved in implementation? Do we need to get the right skills into the NHS to enable scaling and delivery? What are the skills we need to wrap around all of this to get it right? Erik?
It has to be very much a multidisciplinary approach, be that from data engineering, data science, clinicians, allied healthcare professionals. You need the leadership and I think a degree of bravery in those organisations as well to do this, because this is an uncertain space. But I think there's also a real opportunity here in that relationship between industry, commercial, the NHS with academia through that life sciences lens. This has got to be a process of co-design. And I think from an NHS perspective, we need to be strong in saying these are the problems we want to prioritise to solve, as opposed to what's historically been the case is we've got something now, how can we apply it? Because going back to that regulation piece, if you're thinking about this sort of pipeline, putting the monitoring evaluation side, this pipeline of actual development and validation of AI algorithms, the regulators are going to want a minimum viable product around the data, around its quality, duplicates, missing values, data definitions, the provenance, which systems did it come from? Well, these are all the things that can then start to integrate and introduce biases into the end product. And then it will never work when you try and implement it. So it's got to be truly multidisciplinary, but it's got to be in partnership with industry commercial as well.
And challenge-led as well.
And it's got to be challenge-led.
What Andy was saying earlier. Adnan, we've had a question come in. We hear a lot about clinical systems and needs. These often different from what patients feel they need. Are tools being developed to address patient needs? And I suppose just expanding that a little bit, what's the NHS doing? What are leaders doing to engage with patients and the public in this?
So we're very fortunate that the grant supported probably one of the largest interviews with patients with diabetes and end users who are involved in diabetic screening to get their views about how AI, their thoughts about how AI would impact them, their jobs, or with patients with diabetes, what they thought about it, where in the pathway it should be implemented. Because as soon as you deploy AI, you in a healthcare setting, you could tell the patient instantaneously whether they have retinopathy or not. Is that something that's important to the patients? What were they worried about? And actually, the biggest worry patients had was they wouldn't see a human being. Even though the way we'd implement AI for diabetic screening is it'd be the normal patient pathway. Instead of trained technician graders who'd read it offline, the AI would do the first read and there'd still be humans in the loop. So there's all these things we didn't really expect that they would be concerned about. They were concerned about things that we thought they'd be concerned about, they weren't concerned about. So we found there's quite a bit of a mismatch, but clearly there's an education piece that needs to be given as we start implementing these. And without getting these surveys, you won't capture that information. So it's been incredibly helpful, and we've published that to date.
Fantastic. Mary, what's your take on that? How do you involve patients? I mean, take something like the AVT work you're doing or anything else. What's the secret there?
I think it's going to be a range of methods for involvement. I think the kind of work you're doing is invaluable, but I think we're also going to have to move increasingly towards online engagement, because that is where many people engage. Always going to be a role for face-to-face, but we're also going to have to take account of the world as it is emerging.
Yes, and maybe, because our time's coming to a close, let's perhaps finish on that. Erik, AI tools are proliferating really fast. Is there a risk that the kind of uptake of all of this, from your perspective, looking on a trust, is there a risk that the uptake of all of this is really kind of outstripping our ability to monitor it, to check it, to do all of that?
I think the key to it is taking the workforce on the journey with us, because part of the data we can see in the environment is not just the clinical data. We see the buttons that our workforce click when they're doing risk assessment forms. And what we need to avoid is another alertitis. We've had a pilotitis. We don't need another alertitis, because people just go non, next page. So, and there's an interesting area here that is, as the workforce moves between NHS organisations as well, thinking about our trainees, there might be different tools in different organisations. They might trust different products more than other. How do you support them still using them and not reverting to manual process? So there's so much to think through here, let alone the medical legal aspects around it all.
Yeah, definitely. Aysha, last word to you. What's your take?
So I would add to that. I think it's correct that we do take people along the journey, and I think that's really important, education and digital literacy, and it should be applied to everybody in the workforce. So not just clinicians and users that will be using and interpreting the output so that they can question and challenge it, but all the way up to board level. I think also investment in infrastructure. So we've seen if you have the right platform in place, for example, you can scale and evaluations and monitorings, but you also need to have the dedicated teams on the shop floor that can manage the systems that surround AI, that can deliver projects across different specialties and can coordinate all of the different stakeholders. And then finally, you need to have the right governance in place. So you need to know that what you're doing is right, and that should be aligned with regulation and guidance.
Yeah, great. So having the right skills and capabilities wrapped around this is going to be essential if we're going to get it right. We could keep going for ages, but unfortunately we've got to draw to a close now because we're on to our final session. Before we move on though, please join me in thanking very much Adnan Tufail, Mary Dixon Woods, Erik Mayer and Aysha Lewis.